going over these exams. I'll be going over all of the questions, and we'll be doing an item analysis on Saturday. So you're not going to see the final grades till about 2 o'clock on Saturday. But as soon as I'm done, they're going to be posted, and you're going to see a little message, that's sent to you. We have somebody new on here, Rebecca. I don't know how to say your last name, or I'd say hello. She is a new peds professor. She's actually from my hometown and actually has worked in the hospital system that I worked for. So Rebecca's here just to say hello and to, see how I teach, because I've listened to her teach already, and I think she's very similar to me. So anyway, any questions about anything as we go forward? Okay. Well, I sat here and I thought about it. What do I want to do? Because we only have, about 45 minutes until the end of class. So I decided, am I going to do your PowerPoint, or am I going to be doing your Kahoots? And I know you guys, most of you like the Kahoots. I have sent you the PowerPoint already. So let's take a vote of hands. How many wants to use the PowerPoint as teaching today? Put your hand up. Well, gee, that's decisions up. 1, 2, 3, 4, 5, 6. Oh, I guess the Kahoots wins, huh? Is that okay with you? We'll make it work, all right? And you do have the PowerPoint. I've already sent it to you. I believe it was Saturday when you got it, or maybe Sunday. I don't even know the days anymore. So let's go ahead. Let's go to the Kahoots, and let's see how we're going to do today. Give me 1 second. It didn't want to be in the front of the screen, so I've got to go looking. There we go. And there we are. So this week is Cerebral and it is Endocrine. It's pretty some heavy subjects, but I think the way that you're in med-surg right now, there's similar subjects, plus the way I describe things, I think you're going to get it, how things work. And the way that I have mixed these questions up to retest you as we go along, within these Kahoots. There's like 50 some odd questions like normal. So you're going to be getting a lot of concepts there in this. Anybody else want to join us today? All right, let's get going. So week 7, cerebral or endocrine dysfunction. Remember your discussion question? First due on Wednesday night. That's what you do, and start on your assessments. Growth hormone is administered by what route? Now, growth hormone is emitted by the pituitary gland, and it tells you how big and how tall your child is going to be. Why do you think we do height and weight on every single time we see a child? One of the reasons is to see if they're eating nutrition, but also has to do with growth hormone. When you see an extremely short child, well, number one, let's look at the family. Are they all short? That's number one, of course. But if they're all tall, well, let's go looking at that growth hormone now. Now, growth hormone is given in a subcutaneous injection, and it is given up to the point where the child stops growing less than an inch a year. And then we figured they have reached the maximum height that they're going to get. And how much is given, how often is given, physicians are different. Could be every day, every week. That's always up to the physician, but it is sub-Q. And just like insulin, we try to teach our children to give it. Highest priority for a patient diagnosed with syndrome of inappropriate antidiuretic hormone. Well, antidiuretic, which means against urinating, right? So a pituitary gland, posterior lobe, secretes a hormone. And it's too much of, I don't want to urinate, right? Antidiuretic. Because these SIADH, and they look like, oh my God, what do these words mean? Let's break it down. Against urinating, which means you're retaining fluid. So the most important thing to watch is intake and output, because you go in fluid overload. And we also can see if we're doing the appropriate measures to get that fluid away. So we're looking at also weight. Daily weight is the other component. Which of the following are signs of the syndrome of inappropriate antidiuretic hormone? So if you are retaining fluid, and as you've already said, priority is intake and output, absolutely your urine output will be decreased. So you're saying urine output's decreased, and then you're doing your daily weights, and you're seeing the weights getting more and more. They're retaining fluids, and it could get to the point where it goes into the lungs and go congestive failure if we're not careful. What is important to cover when teaching the family about prolyparathyroidism? Now, that is used for hyperthyroidism. Hyperthyroidism, I'll give you that clue. That means the thyroid is giving you too much hormone, and it becomes the point where that could be dangerous. One of the side effects, and we need to teach our families about it if they're going to be taking this, it causes leukopenia, which means low white count, which means you're more immunosuppressed. You are that child that could, get sick quicker. So if we are seeing fever, sore throats, that could be a side effect. So we need to tell the doctor, don't just assume it's a normal cold, okay? Because it could be something else. A Multiselect, an initial sign of diabetes insipidus. Posterior lobe of the pituitary, secreting a hormone. And again, diabetes is not sugar. This is all about urine output. And because that name is diabetes insipidus, many nurses will go ahead and take a blood glucose. Has nothing to do with blood sugar. This has to do with the regulation of urine in your body. What you're going to see is a kid who's drinking, and urinating, and to the point where you go into electrolyte imbalances. And it is an over secretion of the hormone that lets you urinate. So we've talked about not urinating. Well, now we're urinating too much. This is one of those diseases where, again, intake, output, daily weights. We're going to be watching those. A Multiselect. What are the clinical manifestations of juvenile hypothyroidism? Same as adults, except one thing. Remember, children are still becoming adults. They still have to grow. And when you look at the thyroid hormone, it has to do with you growing into be the proper adult. So dry skin, thinning hair, intolerance to cold, constipation, hypothyroidism would be more of a weight gain than a weight loss, okay? Because many of you would say, well, I'm a little pudgy because my thyroid is not good. So it's not weight loss, it's weight gain. And then, of course, as I said, you need the thyroid hormone to grow, to be, who you're going to be. It's part of that whole cascade of things needed with growth hormone, with the thyroid that's going to help you grow and to be, the height about what your family is. A child had a simple seizure. What education would you provide to parents? I mean, you see this a lot in febrile seizures. This is a healthy kid that because of the fever went from nothing to 102 in 20 minutes. The rate of rise was so quickly, the brain just has a spark and they seize. And it could reoccur. So when we're talking any child for any reason, whether the tonic-clonic type of seizures or status epilepticus or, just a febrile seizure, you need to have that child protected. So safety protection. So how do we get a person safe with seizures? Well, they're going to vomit a lot of the time. Turn them on their side. If there's anything sharp in the bed or the crib or wherever they're laying, move it out of the way. If you have a chance, pad those side rails, put the bed flat. And of course, call, the rescue team in. You don't know how long that seizure is going to last. It could be for seconds or it could be on for minutes. So those are things that you would do. We know nothing's going to be forced in the mouth. You'll break teeth. You just protect them from inhaling or aspirating their vomitus. What type of seizure is when the body's jerking, you're foaming at the mouth, and the child is rendered unconscious? Well, that's not the febrile one. That's the other one. So this is called tonic-clonic. This used to be called grand mal years ago, right? We have the petit mal and grand mal, or the tonic and clonic, which is the whole body's going, but it's also the whole body and the foaming of the mouth, but rendered unconscious are some of those things. And usually there's a postictal moment where they have a little bit of memory loss. They don't remember what happened. Absent is when maybe they're blinking or staring, or and the other two are just minor, as like mini, those petites. But tonic-clonic is when your whole body's into it. What notable sign may indicate increased intracranial pressure on an infant? Remember, infants can't tell you their head hurts, right? And they could have increased pressure. How would you know? Well, the easiest thing would be is if they had a bulging fontanelle when resting or asleep. Most infants can have a bulging fontanelle when they're crying because that increases their pressure, but that doesn't tell you increased intracranial pressure. That's not all the time. So when they're asleep, you're going to see that bulged fontanelle. Now, one of the things that's so significant, you can walk into a room of infants and they're all crying, and that one that's a neuro kid, that increased intracranial pressure, their cry is a pitch higher, and it really goes right through you. It's not a normal infant cry. You go, that kid is neuro. You can hear it. That's how distinctive that high-pitched crying is. I call it nails on a chalkboard because it is, and these kids are extremely difficult to calm down. Their head hurts. They've got increased pressure. They've got something going on. Very difficult to calm those kids down. And that cry, you'll never forget it. All of the following increase cranial pressure except what? So you can touch these children, you can suction them, have them coughing, everything, but your heart rate, it does not affect your intracranial pressure at all. Higher or lower, that doesn't really affect it. The other stuff, yeah, they're touching, they feel it. What findings can alert you to a head injury getting worse? So many a times I would have kids come in that slid into third base and their head hit the defender and you heard a big crack and the kid was knocked out. They come in and what would you see? Well, number one, with children, you're going to see them vomiting. Usually not as much as in adults. Kids will vomit with head injuries. They do that with also tumors in the brain too, same thing. But this kid is now coming and saying, well, was I safe? Or we win the game? And then he'll ask again, so was I safe? Did we win the game? And it's over and over again. And they get really confused. Now, their headache would be getting worse. They would be getting more restless and they'd be harder to arouse. So the other ones are completely opposite. So actually you have all the signs there. And they're vomiting, not related to anything they're eating. It's just their vomiting is getting worse and more, or worser, as you might say. A multi-select. What does it mean when you see a fixed and dilated pupil after a head injury? Now, if you ever worked in an emergency room and go in the trauma room, you get a kid who fell off of whatever, one of the first things the physician's going to do is look at the eyes. They want to see what the pupils look like. And when they see, oh my goodness, it's fixed and dilated, what does that mean? Well, absolutely, it's a neurological emergency. There's pressure in there, something's going on. And we know if we let that continue and don't get that pressure off that head with some sort of craniotomy and draining of that blood, we know it's going to be brainstem damage. And your brainstem is the main function of your whole body. That means that child will not come back to any normalcy at all. So anyway, fixed dilated pupil, extreme emergency, and we don't want it to stay there. And these kids are rushed to the OR as quick as we can, sometimes bedside. Which of the following signs and symptoms are more common in children than an adult following a head trauma? So nausea and vomiting, like I said, I don't know why, but adults don't. They get the headache, they get the altered mental status, all of that. But the nausea and vomiting is more on the side of the children. And again, as the headache, the pressure gets worse, the vomiting will get worse. The headache will get worse. It will get to the point where it will wake them up when they're sleeping. What medication can be used for a child with cerebral edema due to a fall? So the kid fell off second floor balcony. You know that there is swelling of the brain. The kid's in ICU and we need to give something to get that pressure off, that fluid. Now, if you remember pharmacology, what is specific to the brain? And that's your mannitol, right? Mannitol is specific to brains, or you could also use it in some sort of chemical exposure. You can use it in kidney problems. But furosemide is usually peripheral edema, or your lungs fill up with fluids. That is great for furosemide. But specific to brain is mannitol. That's one of the things you need to remember. Ray syndrome, what is that? I mean, this is why we do a lot of teaching to our parents, you know, especially when we talk about medicating for fevers or pain. You know, you do have some old-fashioned parents, or you have grandparents taking care of kids, and it used to be everybody got aspirin. Today, we know that the only time we give aspirin is with Kawasaki disease. The only time, and that's monitored very closely because it's children, it's due to aspirin, there's a metabolic problem, and it causes this child to become extremely ill. So we avoid it. Teaching for fever control, pain control, acetaminophen, ibuprofen, nothing else. Febrile seizures usually occur in what? How old are these kids? My firstborn grandson did have one febrile seizure. The mother became a panic about taking his temperature and both her son's temperatures 4 times, 6 times a day, because she was worried of it happening again because it was such a frightful experience. But usually from 6 months to 6 years, that's what the book says. They usually grow out of it. That's the thing. And many parents will say, well, my kid has a seizure. Does this mean he has epilepsy? Well, one seizure does not make epilepsy. It's a combination of many seizures, more frequent, and many in a day. That will put you epilepsy. Febrile seizures are usually one, maybe twice, and rarely again. But it's always due to a fever. Childhood hypopituitarism results in which condition? Well, remember we talked about the growth hormone. That's the pituitary gland, right? So not enough growth hormone causes. Does that make sense now to you? And that's your pituitary dwarfism. They just don't grow. And that could be one of the causes from it. How would you describe precocious puberty? Again, another hormones secreted by the pituitary gland. Has to do with puberty. You know, sometimes you have children, the book says it's 12 years, 4 months is a normal age for girls to start their menses. So about 10 years old, they start showing the first signs of puberty. You know, the breast buds, the first thing, or, you know, the enlarged testicle in the male. Precocious puberty could happen at a girl at age 5, 6 years old. They start getting the breast buds and start growing up too quick. Now, this is something that could cause a lot of issues with teasing from the other kids. So many of these parents decide to give something, it's called Lupron, it's an injection that stops them from having puberty until when they're supposed to. Because even boys will get beards. So it's boys and girls are going to go and get those things that you get in puberty. So precocious puberty, it's too young, too early. A Multiselect. What lab values are important to monitor with a child with congenital hypothyroidism? So the thyroid is T3, T4, TSH. Those are the three. Adults, kids don't matter. It's the same thyroid, okay? Growth hormones is pituitary. And cortisol is your adrenal glands. Make sure you keep those straight, okay? Because it'll tell you what's going on. T3, T4 is about thyroid and the symptoms. And again, it has to do with growth. But growth hormone, too much. And you have gigantism where they're like, can be 8 feet tall when they're done if we don't stop it. Or they can be, you know, 4 foot nothing. That's growth. And cortisol has to do with your steroids, your inner steroids in your body. It has to do also with sex assignment as young congenital babies. How can you monitor a child with hypo or hyperthyroidism? How do you monitor a kid with growth hormone issues? How do you monitor a kid with nutritional problems? How do you monitor a kid all the time? It's height and weight. Height and weight tells you a lot. They're not gaining, they're losing, or too much height, too much weight. There needs to be some sort of investigation. What's going on there, okay? It's not a monthly weight. It's as you go into the physician, there has to be periods of time. Weighing it every month is not going to tell you that information, in a bigger picture, okay? But that's why even in ERs, urgent cares, we do height and weight, and it's monitored and documented. What acid-base alteration would you see in a diabetic child with Kussmaul respiration? Well, diabetic children that are to that point are in diabetic ketoacidosis, where the lungs are trying to compensate for that imbalance, okay? So it tries to slow down and blow off. So you're going to see respiratory alkalosis to get rid of that metabolic acidosis. It's like the opposite. If you're metabolic, you want your respiratory system to work in the opposite way. That means lowering those respirations deep and prolonged, okay? And that's the first start of trying to fix what that elevated blood sugar has done to the body. Now, every HESI has about 4 acid-base questions. So just be aware, I'm going to hit you now with many acid-base questions every cahoots. Multiselect. What would a child with Cushing syndrome look like? Well, this is your adrenal glands now. Or maybe it's an exogenous, you're taking steroids. Like me with my rheumatoid arthritis. They gave me too much, too long, and I looked like that Pillsbury Doughboy. So Cushing syndrome is when you just start getting all this extra, fat, you get rounded, you get red cheeks, but your extremities are still skinny. Your arms, your legs are really skinny. You get hair growth, you get weight gain, striae on the abdomen. I mean, you get to be quite large with it. The book has a great example of it. And this is something, if it's due to you have taken those steroids, every day, just taper those steroids off slowly, and many of those signs will go away, but slowly. A multi-select. You walk into a child's room, temperature's 104.6, and you see them having a seizure. What can you do? What are you going to do to protect that child? Right? Safety. Seizure is all about safety. It's nothing you can do. Safety. So what you're going to do, again, check the area if they're in the bed. They might have something in the bed that could hurt them if they, rubbed up against having those seizures. Turn them to the side in case they vomit so they don't aspirate. And then side rails, put them up and pat them. And you're not going to put no cold water. You don't want to shake down this temperature that quick. That can actually prolong your seizures. So, and of course, call the rescue team. Get them in there also. An autoimmune disease of the thyroid gland. This is usually your young adolescent girls. It can happen in school age, but it's usually those late school age, early adolescents that you see. And it's an autoimmune condition. So this is something that just has to be monitored with medications. You cannot remove the gland. It's autoimmune. You can't touch it. But you're going to see different levels of the thyroid hormones, too high, too low, and there's going to be replacements. My daughter-in-law has Hashimoto's disease, and she filled me into a lot about it. And because those hormones up and down, it creates a lot of emotional ups and downs too, when the hormones are up and down. Addison's disease, adrenal again. How about if I say opposite of Cushing's? Cushing's is Pillsbury Doughboy. You can, push that belly, cushion, like a cushion. Addison's is the opposite. So this is when you don't have enough cortisol and aldosterone being secreted by the adrenal glands. And this is a condition where they're going to need lifelong cortisol and aldosterone. Stress does cause this disease to require more. So if the child is at extra stress, they need to be monitored closely so that they can get those extra that they do need at that time. So this is when they don't get enough. Cushing's too much. Could be that they need this for a lifelong, where you needed a sex assignment to that baby. They didn't have adrenal glands. Was it a boy? Was it a girl? And it is confusing because you don't know. You might have a penis and a vagina, or testicles, and a clitoris. You don't know. So they reassign the gender, and then they'll be placed on cortisol and aldosterone for life, okay? And that's the way that they work with those children. A Multiselect, a ventricular peritoneal shunt. Something about the ventricle and the peritoneum, and it's the ventricle in the brain, the fourth ventricle. And you can see there's a shunt, there's a tube that goes into it, goes behind the ear, comes around the front of the body and into the peritoneum. And we use this when there's just too much pressure up in the head, too much fluid, the body can't regulate it. Many times we use this if we have something called a myelomeningocele. And we're going to go this on week 9, but it's when the lower back doesn't completely close and they have to push back in the meninges, the spinal cord, and close it up after they're born. And sometimes they don't have a good working system of the flow of cerebral spinal fluid. So they put in a ventricular peritoneal shunt to prevent pressure on the brain. Now, how do we work with this ventricular peritoneal shunt? Well, you're going to be measuring that head circumference every day you come on. You're also going to have this little bump that sits there. We never, ever, ever will pump that, push it. That's for the neurologist, the neurosurgeon. And of course, we'll be checking the abdomen girth, the abdominal girth, and seeing if there's like extra fluid in there too. But kids do really well with this. Now, I've seen many come into the emergency room where they had what we call the shunt failure. They come in, it's classic, headache, vomiting. They go in, we do shunt series, and remember, kids are growing all the time. Sometimes they just disconnect. So we need to go in, maybe put a bigger tube, something to help that kid so that we can keep them from having all that extra pressure into their heads. A common sign of Graves' disease includes blank or protrusion of the eyes. Hyperthyroidism. Graves' disease, another name. I had a girlfriend who had bulgy eyeballs and it had nothing to do with her thyroid. That was just her family hereditary, but it's called exophthalmos. Those eyes come out. Ever see the commercials on TV? They got the drops to put in now. The lady with the sunglasses with sunglasses underneath, she puts them in and her eyes are better. You don't have time for TV, right? A Multiselect. Hypoparathyroidism has the signs of tetanic muscle contractions and what? Now, there's a thyroid gland and there's a parathyroid gland, and they do different things. They're right next to each other, but they do different things. Now, whenever you hear muscles, and you're talking about tetany, always think calcium, magnesium, okay? Both of those electrolytes will always affect muscles, the contractions or lack of contractions, all right? So hypoparathyroidism is all about calcium and all about the monitoring of it. If you don't have enough, your muscles won't contract. So you'll have weakness and it will just lay there. There'll be tetany, okay? If there's too much, it's going to be the opposite. Severe muscle spasms, right? Because you have high calciums. So hypo, and hyper. So multi, what are the signs of hyperthyroidism? You know what hypo was? What do you think you're going to see when you have too much calcium? So this is so much that it's got to the point where your hands and feet are all numb. But it also causes that confusions. Too much calcium causes that. And then too much calcium also, that nausea and the vomiting that has to do with it. It's hypercalciulemia. It's not hypo. Hypo is hypoparathyroidism. What does a parathyroid hormone do? Now that I said that, what does it do? Parathyroid hormone. What is it? So the parathyroid is all about calcium. Good. Thank you. Which of the following might be a cause of an adrenal crisis? Addisonian. Too much. Crisis. Something's going on. When you're taking, steroids, that's why they give you Medrol dose packs, which goes from big doses down to little to try to prevent these adrenal crises from going on. But some people will be on 20, 40 milligrams for a month and then just stop. And then all of a sudden the adrenals goes like, what's happening here? I had all of this, cortisol, this, cortisone, what happened? And all of a sudden it will start secreting it and you're going to start high blood pressures, dizzy, chest tightness. You're going to feel horrible because you didn't go lower dose, and decrease, as tapered it down till you got them off. So you'll never, ever have a child or an adult take all of this medicine and stop abruptly. It must be tapered. A Multiselect. The cardinal sign of diabetes insipidus. Remember, this is your posterior pituitary gland and has nothing to do with blood sugar. Now, you're not hungry with this. It's 2 P's only. You're thirsty and you're urinating. Polydipsia, polyuria. Polyphagia is your diabetic, okay? They're hungry. They want to eat. But diabetes insipidus is only about urine. So urine is drinking it and then the output, polyuria. And again, it's increased, like you're urinating. As a side note, if you're an infant and you have diabetes insipidus, you could keep giving them bottles of milk, and they'll want more. Give them a bottle of water and they'll be satisfied. And it works. I've seen it on an infant where we suspected it. They said, give him a bottle of water, see what happens. And the kid stopped crying. The kid was happy. So it does work. A bottle of water for an infant. A Multiselect. Congenital hypoplasia parent teaching should include. This is adrenal hypoplasia. This is not enough adrenal gland. This is when they're going to be getting cortisol and aldosterone for life. This is all about that boy, girl, what did I have? You don't know. So these children, as I said, are born with 2 types of gender sexual organs, whether it's a penis and a vagina or testicles and a clitoris, it's some combination. So I've only seen one in my lifetime. And what they do with these children, number one, they have to assign a gender. Sometimes they'll go in and see what's inside, do ultrasound. Sometimes they'll do hormones testing. But they don't have any complete male or female. So they'll never have babies. They just don't have the capabilities. And this is the one that's going to need cortisol and aldosterones for life because they're neither male or female. They don't have the proper equipment. And then, together with the physician and the parents, they decide, is this a boy or is this a girl? Okay. I've only seen one, and it was different. This one had a testicle and vagina. It was different. What causes type 1 diabetes? I do like the answer, too much candy, right? So we know that diabetes has to do with the pancreas, and the pancreas secreting insulin to be able to take carbohydrates or sugars and break them down and be used by the body. Well, what happens with type 1 diabetes, some sort of autoimmune process has broken down those beta cells in the pancreas and they don't secrete the insulin that they should. Type 1 diabetes will require insulin. Now, I have a question. If you have a child at age 2 who comes in like in a DKA, high blood sugars, recent weight loss, urinating, hungry, thirsty, and they say that this kid's going to need insulin and it's type 1 diabetes, will they ever become a type 2 diabetic as they get older? Can a type 1 child become a type 2 child when they grow up? No, you're absolutely right. No, they can't. Because once you don't have insulin secreting, they don't like grow up and they don't start secreting. It's not like febrile seizures, they'll grow out of it. This is not that. Once you're type 1, you're always a type 1. You can have type 2 become none, 2 become 1 to go back to 2, depending if they're maintaining and diet and weight loss and that, but they'll never convert. These young children, they'll always be type 1. Which statement about a pheochromocytoma is correct? Now, a pheochromocytoma is a tumor on the adrenal gland. This helps me understand if I had too much adrenal hormone or cortisol in the body or go into, a crisis, what would happen? Adrenal crisis. Well, a pheochromocytoma is a tumor where you have periodic times where it secretes this little liquid. It's basically epinephrine. So what do you see? All of a sudden the kid gets tachycardic, blood pressure goes up, tightness in the chest, gets dizzy and feels crazy, and feels like their heart's beating out of their neck. And then it stops. So they do this whole cardiac workup and they can't find anything. So finally, they do a CAT scan or an MRI of the abdomen and they find the tumor there. These are things that they have to go in and remove that tumor. When you ever have a child or an adult who has a diagnosis of pheochromocytoma, you need to be monitoring their vital signs closely because it's like all of a sudden, it's not all the time. It's like all of a sudden it will go up. The kid starts complaining, the adult starts complaining. You need to do a set of vital signs. See where you are. Where's the heart rate? Where's the blood pressure? So I'll multi-select. What action should the nurse implement in the care of a patient with a pheochromocytoma? These are very silent and they're very difficult to diagnose. They really are. If it was all the time, you'd figure it out. And everybody always thinks it's the heart, but you're going to look for heart rate and you're going to look for blood pressure. So hypertension, heart rate is what you're going to be monitoring. Frequent vital signs, minimum of every 4 hours. And any complaint that I just said, that headache, the dizziness, the tightness in the chest, feeling it, we're going to be monitoring vital signs. We want to know where those numbers go. A multi-select. Nursing care of the unconscious child should include. There are kids that, do fall off of buildings. I've seen them off second floor balconies come in, and they can be unconscious, and they're admitted into the ICU. What do we do to take care of them? Well, we're definitely going to be looking at their neurosigns, checking their eyeballs, seeing if they're moving, or the response to them. Of course, vital signs and temperature. Temperature and fevers we don't want with this child. We don't want to do anything to disturb the brain. Also, intake and output's important. We do not want to overload this child with extra fluid. Extra fluid can create more problems, in a brain that maybe is already swollen. So INO, vital signs, and neurochecks, very important. Symptoms of diabetic ketoacidosis are so then you ask, what is diabetic ketoacidosis? Well, diabetic ketoacidosis is when the sugar in the body is not being utilized. There's not enough insulin for whatever reason. And the body says, I'm hungry. You need to feed me. Okay, I'm going to look for my own food. Well, what food sources are left in the body? Well, you have fats and proteins, right? So the body says, all right, I'm going to start eating proteins. And they eat proteins, and the byproduct is ketones. Now, sugar's not being used, so you smell it coming out of their breath. It's such a high glucose. Also, you're going to test the urine. You'll see glucose in there for sure, but you're also going to see 4+ ketones because the body's hungry. It's eating protein. Ketones are coming out. So does that help you understand diabetic ketoacidosis a little easier? I'm just hungry for food. Give me protein. I can't use sugar. A multi-select. An adolescent with a BMI above 95% has been urinating a lot. What tests can you anticipate? It's the only symptom. It's a big kid to the point of obese, and they're urinating a lot. Like, what's happening? Well, it could be a urinary tract infection. That could be it. But because of what's going on, we're going to do a hemoglobin A1C. The kid's overweight. Possibility the kid's diabetic. Could be. So absolutely. And then we're urinating a lot. We're losing electrolytes. So good job. You guys thought of most of them. Diabetic ketoacidosis is caused by what? I just told you. What do those words down there say? The same thing. So no insulin, you're not eating carbohydrates. My body says, I'm hungry. You're not feeding me because they can't eat the sugars. So they eat other things for fuels for energy, which is protein. And they eat the protein, byproduct, ketones, okay? Another multi. The child's admitted with blood sugar greater than 600, large ketones in urine. What is your priority intervention? What do you do first? What do you do first when you have a large, high blood sugar and ketones? Number one, Number one, you start an IV and you bolus them with normal saline. Never bolus with sugar on these kids. Their sugar is high enough. You're going to do IV normal saline, and then you hang up a slow, continuous, regular insulin drip. And you're going to be monitoring blood sugars initially, like every 5 minutes, because you don't want that blood sugar to get really low. Once you get all the labs back and you find out where the potassium level is, then you replace it. That's not your priority. Your priority is volume, give them fluids, get that blood sugar down. Kids who come into the ER with these things, I've seen blood sugars up to 1100. And I've also seen when we did an ABG, their pH was 6.9. This is almost not the ability to live. That's how sick this child was. Pale, just diaphoretic, just leaning over, really just delirious. Started an IV, gave bolus, got the sugar down a little bit. The kid was pink, alert, and oriented in an hour. It's amazing how you can turn these children around that quick, okay? So priority, volume, and then we'll start that insulin drip very slowly. A diabetic child complains of feeling jittery and the blood sugar is 45. What's your best treatment for the child? And the key words here is the child is complaining of feeling jittery. So a glass of orange juice is fine. You don't have orange juice. What if you have a packet of sugar in your pocket or a little sugar candy? Go for it. Something to get that blood sugar up immediately. And one of the things that when we're working with children that are diabetic, they can play whatever sports they want to, but they should eat before they go play and test their blood sugars before they go out in the field. And they need to keep hydrated and they need to have snacks in between because they're burning off all the energy. They can have a normal life, but they must be very conscientious on eating, testing blood sugars, making sure they're hydrated, and have those little snacks if they're out there burning all their energy, okay? Your patients experienced a head injury. What would most concern you? Head injury. And pupils look okay. But you got swelling going on in the head. It's that decreased urinary output. That is what is alarming. It's gone there and swelled an area which is affecting the diuretic hormone in the brain, the pituitary gland. It's deep inside. So it's going to be affecting it. So watching that urinary output is one of the things that we think of head injury, we look at eyes and neuro and movement and pupa. We don't think about urinary output, but it's extremely important to remember that inside the head are all these things that regulate the urine output. A multiselect. How do you detect ketoacidosis? You know, ketoacidosis is because you've eaten protein, and you eat protein because your blood sugars are high and you can't use them. So blood sugars are elevated, and you're going to find the glucose in the urine, and you're going to find the ketones there also. All goes hand in hand. Dehydration, maybe, but those other three things are quick. Yes, it is. Dehydration, you see an elevated heart rate, maybe, but the other three for sure. A multiselect. What would alert you that a child's head injury is deteriorating? There's our little boy again. What's he showing you that says something's wrong? There's increased pressure in my head. You know, if the kid's already going to be confused, if it's getting, deteriorating, you're going to see them, you can't wake them up. It's to the point where you have to almost take their nipples and pinch them to wake them up. Sometimes we do that in some of these severe head injuries. And the kid is now becoming restless. There's something going on. The kid's not oriented, not easy to arouse, becoming restless. We know that something's going on. What do? We're going to call the doctor. Take the vital signs, get the doctor. A child's been diagnosed with bacterial meningitis. What is the nursing priority of care? Now, there's two types of meningitis, viral and bacterial. Viral, we treat it just like an upper respiratory. You have ibuprofen, acetaminophen, rest, fluids, something for the headache if you need it. But bacterial is all about a bacteria in the meninges and in the spinal column and in the brain. And it's extremely painful. But the symptoms of either viral or bacterial look the same. What you're going to make sure, number one, is antibiotics. You don't fight the infection, it's going to continue. When you do the spinal tap, which is whenever you suspect a meningitis, you're going to be doing a cerebral spinal fluid, looking at sending it to the lab. If you see it clear, it's going to be viral. If it's white, milky, almost positive that's going to be bacterial. Those are white blood cells in there. And you're going to see, different parts of it that's going to tell you also. What is the primary cause of injury associated with submersion? Or if kid drowned, kids at the bottom of the pool, somebody had to go get them, had to, bounce on their chest, they vomited, and, all of a sudden they woke up. So are they okay? Because they're up now walking around? Well, the thing is, it's not pneumonia. It's sort of that aspiration pneumonia from fluid, but it's the hypoxemia, that hypoxia that occurs because you're underneath and the water has filled up your lungs. And now you're not getting oxygen. That's the primary cause. The thing with drowning, you can have a acute respiratory distress syndrome 3 days after. These kids are hospitalized for 3 days and they're monitored with a O2 sat monitor, and they're usually in a step down type ICU because it could be 3 days later and all of a sudden their respiratory rate stops and their saturations go down and they become extremely ill. So hypoxia is the primary injury because of the aspiration of all the water and being down there underwater. You can't breathe. And last question, a multi. What CSF lab results correlate with bacterial meningitis? Well, there's that grossly white, like I told you, I've seen it almost looking milky. I mean, that's a bad one, but it's not the worst I've ever seen. It looked like just cream. It was that white. So in bacteria love sugar. They go yum, 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 and they eat it up. And they just leave the protein alone. So you're going to see a elevated white count. I mean, it could be too numerous to count. I've seen that. Greater than 100, greater than 3,000. I mean, you could see them very high. And then you're going to see low glucose and elevated protein. Glucose of 30, protein of 70. Normal looking thing. So increased white count. So there you are. You've had this week's lecture in a cahoots, and I think I covered it all. Nicole, number 3, good job. Della, number 2, whoop, whoop. And number 1, Wendy, good job, Wendy. JP and Raphael, good job, Raphael. You had a good week, Raphael. You don't even realize how good. So there's one announcement. You know, I always announce something about a score on an exam about something. The most improved of scores from exam 1 to exam 2 this week goes to Raphael. You kicked it out the ballpark. He, struggled on the first one and then he kicked it. So, we got to stick up for our fellow classmates. I think that's great. Yeah, I can't give you scores, but Raphael, don't worry about it. I mean, amazing. Remember, anybody who wants to see me go over their exams, I can do after Saturday. I can't do it before then. I know some of you are still going to take your exams, and I wish you good luck. Again, I'm going to tell you, make sure you read the questions. There's some tricky questions there that ask for the opposite of what you think. So always go back and make sure you look at the question when you have an answer in mind, okay? So thank you guys. Another great week. I will see you next week. And remember your discussion questions, okay? Take care, guys.